All right. Okay. Welcome. My name is Sloane Wesloh. I'm looking forward to presenting to the Pitt HPS Club today. I am a graduate student here at Pitt HPS in my third year, and I work primarily on philosophy of medicine, but I'm primarily interested in the electronic medical record. This is a pretty niche interest, but I'm interested in sharing it with you guys. And more primarily, I'm interested in sharing this as like part of a more informal story of like, what do you do in grad school? How did you get here? Who are you? What's going on? Things like that. So my story, it's a little bit complicated, but basically a couple of years ago, maybe like 8 years ago, I was working as a medical scribe. So I was following a doctor around with a computer, and I was working in an emergency department. And basically, my job was like listen to what the patient says, listen to what the doctor says, and write literally everything down, but translate it into like medical language. So translate the patient's complaints into the language that we want in the electronic medical record. So translate it into a patient a present history of present illness, into medical decision making, into things like that. And I had no previous like medical training. I also had no philosophical training, anything like that. This is before I went to college. I was on sort of like a gap year. But I got really interested in these templates that we were using. So basically, like as I would type up these notes, as I would work with the same doctors over and over again, they were like, hey, like, every time we see a strep patient, like they have the same complaints. Why don't we start creating these templates for them? Like you can copy them from these other doctors who work here, and then we can alter them based on like what I see as a strep patient. And so what that means, and I'll explain this later in the presentation, is that like they would have a template that says like patient presents with this complaint and that complaint, and then on their exam they have this. And then at the end of that preset note, it would say they were diagnosed with strep throat. And obviously these were like editable notes, but it was something that was set before the patient even came in, but the doctor would basically be like, listen, I think this patient has strep throat. You can pull up that template. We can like cut down on some time here. And I thought that was super fascinating. Like, how is the doctor making this judgment call so quickly? How are we using like nowadays? I'm thinking of this in terms of like what sort of evidence is that? But I didn't really have the words to describe what I was thinking at that time. But I sort of put that like interest in my back pocket. And I came to Pitt thinking I was going to be a pre-med student. And then I took like Bio 1 and Chem 1, and I was like, man, that was hard. That was really hard. But then I also took Intro to Phil Sci with Colin Allen. And while I was in that class, we read, I mean, all the classics that you guys read, including Kuhn, which like really got to me. But I was still thinking about like this EMR stuff. And so I got really excited about paradigms and this EMR stuff, and I like tried to mash them up. And I was thinking like, well, what if these templates are like little like micro paradigms of disease? An idea now that I'm like, that's like kind of crazy. But like I was really excited about that at the time. I was like, what if like each of them is like a concept of disease that could be a micro paradigm, and then like they change. And like Colin was excited about that too, and I was excited that Colin was excited. And it turned out that like that was something that people hadn't really thought about in those terms. And he was like, I think like you could maybe do something with this. So that in turn like turned into my writing sample for graduate school. And somehow that worked out. And so I ended up here. But before that, I actually was a medical scribe again, like during a gap year, after I graduated. So then I was like a medical scribe manager, and I managed like 200 medical scribes remotely, which was super interesting because then I was working not with like one EMR system, which was Epic first, but I was working, I think at that time, like I had to learn over 20 different EMR systems and be able to like go in remotely and like help people. So then I was like, okay, like these templates are everywhere. Like this is a thing that's going on everywhere. And so it just kind of made me think about this a little bit more. And since getting here, I've been like, okay, philosophy of medicine, no one's talking about this. Like electronic medical record systems, no one is talking about this. And I think it's a really cool tool. And that's been my goal in the past 3 years as a graduate student is like, so in the first couple of years in the program, we come in and we're taking coursework. And we're starting to think just this year about like, what do we want to do for our dissertation in the future? We have like 4 more years, 3 or 4 more years in this program to write our dissertation. And this year we're starting to think about like, how are we going to basically like try to cast our dissertation and have that be accepted by a committee who wants to work with us. And so this year I'm thinking like, okay, how am I really going to work with the EMR and make it something that is like a tangible project? And so I'm hoping to talk a little bit about that today. Basically show you guys a presentation that I did this summer at a conference for history and philosophy of biology. Basically, this presentation was about the electronic medical record as a tool for thinking about evidence in medicine. I also think it can be talked about like in talking about like concepts of disease and bias and who gets to contribute to knowledge, things like that. But I think maybe starting with evidence is like a cool way to start with that. Anyway, I will jump into that, but feel free to interrupt me at any point with questions or anything. Even if it's like, what is that word that you just used? But feel free to interrupt me. It's totally fine. All right. So the goal of this talk is to demonstrate how the electronic medical record can inform how we understand what evidence-based medicine is, as well as broader arguments about what counts as evidence in science, and in turn, how we can come to understand the role of values in science. So evidence-based medicine is a movement in medicine that started in the 1980s. And it and electronic medical records intersect around like a very seemingly basic question, which is how should we make a medical decision? So when we have to decide something as a clinician, like a diagnosis or a treatment decision, a treatment recommendation, what sort of factors do we want to include when we make that decision? So is it just a matter of like using logic to figure out what data points point to which diagnosis? Or are those like social values which help like influence which data points point to which diagnosis or treatment recommendation? So the main point of my talk is to demonstrate that the electronic medical record actually has like historical and philosophical importance for this question. And to show this, I'm going to dive a little bit into the history of medical records, mostly because I think it's like super interesting. But first, I want to give a little demonstration of what the EMR in action looks like today. So say you're like a doctor, a clinician sitting, maybe working in like an urgent care clinic or something. So a new patient walks in, they're here to see you, they sit across from you. And you ask something like, what brings you in today? And that patient might say like, well, a couple of days ago, I got this really terrible back pain. And then this morning, my left leg, like it went completely numb. And so my question is, how do you as a clinician decide what to ask next in order to reach a diagnosis? And so my little image here, like the little clip art, it shows a doctor with a clipboard and a pen, but today this is completely inaccurate. So a more accurate representation would show a computer between the patient, who's not shown here, and the clinician. So it's situated between the patient and the clinician, and it mediates the encounter. So every bit of information that the clinician is asking for is not only inputted into the computer, it's not only recorded there, but it actually guides the clinician in asking information. So when the patient says they've got back pain and this leg weakness, the EMR can actually help us pick out some sort of diagnostic pattern. And later I'll return to like what this diagnosis is actually going to be. But right now I just want to say like the computer is going to guide us as to what more specific questions we want to ask in order to confirm or refute some sort of diagnosis. So they might ask like, have you had any urinary incontinence? Have you had any fever? Does anything make the pain worse or better? And basically the claim that I'm going to make is that the computer actually helps to tell us when a piece of patient recorded data, what the patient says, actually counts as evidence for a diagnosis. So the reason why this is interesting is because there are a lot of arguments about why or what we should treat as evidence in medicine or in science in general. So I want to examine this claim under the context of evidence-based medicine, which is a full-blown movement in medicine about what counts as the best evidence for prescribing a treatment or for making a diagnosis. So the talk is split into two big sections. I'm going to start by talking just shortly about evidence-based medicine, and I won't go too in-depth about this, mostly because I'm more interested in the EMR. I think it's more interesting. And then in the last part, I'm going to connect both and make the claim that today part of what determines diagnostic evidence is decided by the EMR. So the main basic idea that prompted this movement of evidence-based medicine in the 1980s was this tension in diagnosis between clinical authority versus actual evidence to make a diagnosis. So when we collect the information about a patient's ailment, when they come in and we ask, like, what brought you in today? That data can be used in a lot of different ways. So back in the 1980s, the worry was that we were collecting like a hodgepodge of data, but we weren't actually using it logically in any like consistent, systematic manner. So instead, they were worried that we were just using clinical authority to make a diagnosis. So we might say like, well, those symptoms that you're reporting, they sound a lot like cases that I've previously had where a patient had a back pain and I previously diagnosed it as sciatica and I treated it successfully as sciatica. So knowing it sounds like sciatica, I can ask some questions to rule out more dangerous syndromes, and I can perform an exam guided by that intuition that this sounds like a sciatica patient, and then ultimately diagnose that patient with sciatica. And that seems a little bit concerning to us because we're thinking, well, you might miss out on a really important diagnosis because you aren't thinking about other things that might be important or dangerous. So what's my alternative? It's evidence-based medicine, which is really concerned with using evidence when we make clinical decisions. Really, they were primarily concerned with treatment decisions. So they heralded the randomized control trial for providing evidence about choosing the right treatment for a particular condition. But they were actually also interested in this idea of like, how do we actually use evidence for making a diagnosis? And this part of EBM is a lot less talked about, which is why I bring it up now. I think it's a really interesting part of EBM because also evidence here looks really different. Because we're talking about data points that are like things people are saying, basically, things that patients are reporting. So proponents of EBM thought that we should treat diagnostic data systematically and logically when we are making diagnoses. So that is some piece of data, whether it's a lab value or a patient-reported symptom, actually counts as data for a diagnosis. And if it does, then we can count it as some part of like a logical puzzle for that diagnosis. Basically, they centered the idea that clinical judgment and authority wasn't enough to practice good medicine. Having authority or having experience with seeing patients, having some like priors basically wasn't enough to do medicine well and make accurate diagnoses. And instead, they wanted to connect data directly to diagnoses. And in order to do that, they needed to turn to some sort of logical reasoning. And this move makes some pieces of clinical data, some like lab data, some patient-reported symptoms, signs that clinicians see, count not just as data, but actually evidence for a diagnosis. Does that make sense? Good, okay. All right, so that's all I've got to say about EBM, and now we're going to move into what I think is super interesting stuff, which is the historical material of this talk. So it's a very like HPSE talk where I have some philosophy in the beginning, some philosophy at the end, but now we have like historical meat basically in the middle. So the question here is like, where does the computer fit in here? If we're talking about electronic medical records, we've been talking about like logic and data, but what about the computer? So to talk about how the electronic medical record came to mediate between data and diagnosis, I want to go back to the 1950s and some guys, wow, these images did not come out well. That's too bad. So on the left, we have Robert Ledley, and on the right is Lee Lusted. So in the 1950s, these were two physicians who were working separately, actually, but they were both really concerned with what they called errors of omission in diagnosis. And all that is like a missed diagnosis. So if you see a patient and you ultimately diagnose them with something else, but you missed the correct diagnosis, basically. So it seemed to them that this sort of error was coming from a burden of diagnostic reasoning. So in 1959, they actually came together. They wrote a hallmark paper in Science called The Reasoning Foundations of Medical Diagnosis, in order just to simply describe how diagnostic reasoning works and why it's a burden, and why it leads to errors of omission. So that paper basically went like this. They claimed that making a diagnosis is basically a cognitive puzzle. So they think that it's like memorizing a catalog of symptoms and signs, and which combinations of symptoms and signs equals which disease. So the example below is basically saying frequent urination, frequent intense thirst plus frequent urination in the setting of elevated glucose equals type 1 diabetes. So those are symptoms first, and a sign equals some sort of disease. So basically saying here are some symptoms, here's a sign, it might point towards that disease. But that's really not the most important thing they said, this sort of logical puzzle they set up. Really, they wanted to say a doctor doesn't just diagnose one disease. No doctor specializes in just one disease. Instead, when a clinician is sitting in that urgent care clinic or wherever they're sitting, they're going to be sitting there with a catalog of diseases in their head. So a patient comes in and they say I've got frequent urination, I'm thirsty all the time. Then a patient is gonna, or the doctor is gonna start flipping through that catalog in their head. They're gonna say well, these symptoms might line up with type 1 diabetes. They also might line up with a UTI or something more rare like diabetes insipidus. Or maybe renal disease or something like that. So we've got to rule these things out by looking for more signs or performing lab tests, things like that. So that's the cognitive burden of disease, is that they've got to remember all these different patterns, they've got to remember all these different diseases. And then that's not all, though. There's a logical puzzle to the disease remembering as well, that symptoms plus sign equals disease. And so the third claim that they came up with is that the computer is the right tool, basically, to deal with this problem. So if there's a problem with a cognitive burden of disease, then we need something to ease that burden. And the right tool at the time, in the 50s, the computer was being used for a lot of stuff. And the right tool for this burden was the computer, because it can basically, we can input an algorithm to solve some sort of function. And we just need to know the right information. Basically, we need to input what symptoms and signs really do equal what disease. And so an excellent way of sort of exemplifying this information or this theory is this device that Ledley came up with. So he called this his metal brain. And this was something that he really used, but he came up with this right around the time when they wrote their 1959 article to demonstrate this logic of diagnosis. So basically, it allows users to diagnose certain diseases of the tongue, so it's specific to the tongue, by entering combinations of symptoms, including signs, descriptions of lesions, things like that. And not even specific to the tongue symptoms, so more constitutional things like fever, things like that. So by pressing combinations of buttons on the right where you can see different symptoms and signs, then the device would light up with a diagnosis on the left. So this is basically saying here, that combination of symptoms plus signs equals diagnosis on the left. And if you entered something that literally wasn't even possible, there's a button or a light up thing on the top that says this condition is not clinically possible. But the hope was that you would input something that would end up with just one thing popping up. So maybe that condition was due to diabetes, for example, and that would light up. And you could actually see okay, the pattern is resulting in one diagnostic finding. And so Ledley actually told the press, this would assure the doctor that every single possibility will be dug out of the metal brains of the computer. So he's basically saying look, I don't need to remember this now as a doctor because the computer's got it. If the computer can hang on to all these different logical puzzles for all these different diseases, then I don't need to actually remember them. I don't need to remember the symptoms and signs for syphilis, I guess, or the lesion on the tongue that would represent syphilis. But the computer can remember it, and then I can put this giant device in my pocket and carry it around me on the wards, and that would be a relief to my cognitive burden. So it's a good representation of their idea, basically, even though this is a huge device and specific to the tongue also. So oh yeah.
I'm just wondering, what were the critiques for this?
Yeah, so critiques for this, it was interesting. The main critique was like, well, do we need doctors then?
That was my critique.
Yeah, so they actually there were some popular like media posts that were like, well, the doctor is now a computer and doctors are going to be fired soon.
Right.
So there was big concern that like there was going to be a boon and doctors were going to be out and we were just going to be seeing computers, and that didn't happen, obviously.
Right.
But we actually see a similar thing now with like AI coming up, where it's like, well, we need doctors now. But that sort of fell flat then, because maybe there was something to clinical judgment, which is actually where I'll be getting, like where I'll be going in the talk. Because basically, like, even though they thought there was an impending revolution of automated diagnostic reasoning, this actually completely fell flat. So nowadays we use the computer to record and store medical information. And even though I still think there are some ways that this plays a role in the electronic medical record, it's not like this.
So was this idea accepted by the medical community or more so rejected?
So more so rejected, I would say. Yeah. So you don't see this in like hospitals or anything like that, but you do see the influence in like different studies, where they start going out and saying like, well, do you think this would be applicable to this sort of disease? Like, can we maybe see if Cushing's syndrome, if we could automate this sort of diagnosis? And in some diseases, it was actually super successful,
right.
Where they saw like actually it increased the number of diagnoses and helped patients ultimately. But then in other diseases, they were like, this is not going so well. It's not useful. Yeah. So the next person I want to move to kind of traces the influence of the previous people, Ledley and Lusted, in characterizing diagnosis as a logical process, but helps move us towards the EMR, and that we start talking about like actually recording medical information. So this is Dr. Weed. I think he's my favorite person in general. And so he is, some people call him the father of the modern electronic medical record system. And if you look him up on YouTube, there are some like awesome videos of him talking and lecturing about about medical records in general. So he went to medical school in the 1950s. And then after completing medical school, he decided he was going to go back to the bench and just be a bench scientist, work in biochemistry. And then after a few years working in the lab, I honestly don't really know why, but he returned to the hospital, started working in the wards again. But at that point, he was like completely struck by this difference between bench science and clinical medicine. And he was like, this is a disorganized disaster. He was like, the way that you guys are recording information is going to result in chaos and disaster. Like, you are not being structured or rigorous at all in the way you record information. And so this really famous quote he said, the practice of medicine is the way that you handle data and the way that you think with it. The way that you handle it determines the way that you think. So what he was directly referencing here was the medical record. So this is just a sort of sample note of what it looked like when Dr. Weed like started working. So the issue here, this is just a medical note in a patient record. The issue here is not like the messy handwriting or anything like that. Basically what he was concerned with was that it was like not logically structured. It was unorganized, where lab values were, where patient complaints were, where the diagnosis was. Like you see lab values down here, different dates with different complaints, things like that. Obviously, it's not very well structured. And so he starts making the claim, he's just gotten back from working on the bench, and he starts making the claim that we need to treat medical notes like lab notebooks. And so this is just like a very, very basic example of what a lab notebook looks like, that, this would come from like a high school lab report template. But this is what he was thinking. He's like, we need to start with something that would structure ourselves so that we can see why we reached the conclusion, and what we were using to reach that conclusion. And when he says conclusion, he was talking about a diagnosis, essentially. So he wanted to make sure when we reach a diagnosis that there were actual logical reasons for reaching that diagnosis. So when he said like we should structure the medical record, he was talking about these very specific components of the medical record that were actually already in place, but he was talking about structuring them in a specific order. So I want to run through them pretty quickly. You guys might be familiar with them, being exposed to the medical world in some respect. Basically, so Dr. Weed, he came up with this idea called the SOAP note. This is super popular nowadays, but it's called subjective, objective, assessment, and plan. It's how we separate the medical note nowadays. But these are the different components of the SOAP note. So we need to basically separate these into what counts as subjective information, objective information, or the assessment and plan. And so Dr. Weed said, well, the first part of the note should be subjective. That should be the history that the patient tells all in their own words, and the review of systems. Nowadays, we don't do review of systems anymore because insurance has decided we don't need it. But the review of systems was just patients saying like yes or no to symptoms. So that was also in their own words. But this is all subjective information because it's coming straight out of the mouth of the patients, and it shouldn't technically be mediated by the physician's decision about whether or not the patient has that. And then objective information would be something that's like directly observable by the clinician. So the physical exam findings, labs and imaging, those are all examples of objective information that's supposed to be like straight up data. And that comes after the subjective information in the note and before the assessment and plan, which make up the very last part of the note. And this is supposed to synthesize the objective and subjective information in order to make a diagnosis. So the assessment is just the diagnosis, and then the plan is the treatment that follows from that diagnosis, basically. So the logical structure here, basically, is that basically we have these different headers: subjective, objective, assessment, and plan. And first we want to like combine or synthesize the subjective and objective information into the assessment. And then given that subjective and objective information, we can make a diagnosis. For example, like a patient has frequent urination, intense thirst, they have diabetes. Given what I observe and what the patient has told me they've observed, I'm able to make some sort of like clear assessment of the situation. And then the second part is basically, given a certain assessment, I can make a plan that logically follows from that. So I can start the patient on insulin, something like that. And then this is like the rough logical outline from that. It's honestly not super important. It just makes logical sense from what we've already said. If we know that S plus O leads to some assessment and that some assessment leads to a plan, we could honestly skip the assessment and go straight to the plan. So Dr. Weed is just saying, like, if I look at some plan, I should know what your subjective and objective information is, even if I don't know what the diagnosis or assessment is. So he was really concerned with this idea of like auditing and going back and making sure that medical students were like learning from their notes and doing a good job, basically. So after Dr. Weed came up with the SOAP method, things like took off for him. It's used nearly universally now. But Dr. Weed had introduced that on paper. He hadn't even gone electronic with it. So you could buy notebooks with areas delineated for each part of the SOAP method. But in the 1970s, things were really starting to get digital in more of a graspable sense than when Ledley and Lusted were doing that. And it was going that way because it took pressure off of people's cognition, basically. So they didn't have to like remember a ton of things, just like the concern was with Ledley and Lusted. So Dr. Weed also took note of this. He also wanted to take the cognitive load off of people. And so he decided to take SOAP online, and he developed the PROMIS system, which is the problem-oriented medical information system, which you see here in this picture. And basically the idea here is that it couples the data that you enter about patients in the system here with some larger textbook knowledge. So what is textbook knowledge? It's literally the stuff that you get out of textbooks, because Dr. Weed sat for 2 years with his friends and he sifted through textbooks and was like, here are the symptoms that define this disease. So when we say S plus O equals A, we're saying like, for this disease, here's the S and here's the O. So for type 1 diabetes, it is intense thirst and frequent urination and some other things. That's just a sort of reduction of what that might be. So for the knowledge coupling situation for this, he called this knowledge coupling. You'd input your patient's medical information and then, so their symptoms and then their signs, and then you'd literally hit a button called couple, and it would pop up with the textbook information and say like, you've matched some of this criteria and maybe you should consider this diagnosis. And then it would basically tell you like what of your information you had put in counted as evidence under that textbook knowledge. So I want to run through like a brief example of what this might look like. So the first thing that a patient would do with this like old touchscreen device, they would come in and they would sit down and answer 175 yes or no questions. Yeah. And it's like an old device. So like you'd press a thing and then you'd wait like, 30 seconds. So it was fun. But he wanted to gather like all of the data. He didn't want to leave anything out. So not even knowing what the patient's coming in with, he's like, we need every symptom, every sign. And so these are just a couple of example questions because we aren't doing 175. And so these are all just yes or no questions. Maybe they don't have abdominal pain, but they do have back pain, some things like that. We would call that like negative for abdominal pain, positive for back pain, and we would generate like a list like this, for example. So from those initial answers, the patient's record is going to have like this huge review of systems, basically, and a huge list of negatives, some positives, which are going to be vital for a diagnosis. But then we would also gather some objective data from an exam, a physical exam. Maybe the patient has like a fever that we measure, some like motor reflex diminishment, something like that. We put that in the record right next to the subjective information, and then we get to hit couple, and then it's going to pop up with an alert and basically say like, hey, the information that you put in here, the combination of fever, low back pain, numbness and tingling, urinary incontinence, without these certain symptoms may represent cauda equina syndrome. So patients with this syndrome might also have a fever, some things that like you did not input, or that you actually did input. And then it would have a section for references as well. It would say like, hey, check out this textbook where I got this information. And so this, it's hard to see on here, but this is an actual picture, a couple of actual pictures from the machine. So it's a different example here. I think the thing here is like they represented with like, or presented with abdominal pain. But basically what these numbers are showing under observation/total is, so for this number 1 diagnosis, mesenteric vascular insufficiency, there's a possible total number of findings for it of 10 symptoms or signs. And they're saying like in what you've inputted, we'd see 8 of those possible 10. So that's pretty high. We're like, they're putting that as number 1. You should totally check this out. And on the right, they're saying like, we suggest this cause because these findings are present. And they also say references not displayed. But then there are also other ones possible that they're like, hey, like, they've got one symptom of a small bowel obstruction, but we're not like ruling that out. Maybe you do want to check that out. That could be important for you. So you might ask, like, is this what we're using today? And the answer is no. So Dr. Weed's knowledge coupling system was used in a couple of hospitals in Vermont where he was based, somewhat successfully, but it's not being used to diagnose us in clinics today. So Weed eventually sold the company software to a company that used the interface not to assist doctors in making diagnosis, but actually patients. And you might have been thinking to yourself, wow, this sounds a lot like WebMD. And you're exactly right, because Dr. Weed decided to sell his company to Dr. Oz, who owns WebMD. I know. I know. Sorry. So this gets kind of interesting though, because if we put a lot of emphasis on symptom recognition in diagnosis, then it seems reasonable that like some of the power in making a diagnosis might be shifted like outside of the clinic onto a patient, because symptoms are things that patients know best. But this also goes wrong a lot of the time. So here I've inputted some symptoms like increased thirst, urinating more frequently, and they're like, yeah, maybe fair that you could have diabetic ketoacidosis, so that would be a finding for type 1 diabetes, but also like maybe actually you have low potassium, which is not relevant to this at all. And I've even inputted like female age 12, because actually when I went on to WebMD when I was 12 years old and I had these symptoms, it told me that I had diabetes insipidus. And I was super curious about this because I went to the doctor and I was like, I fully believe that I have diabetes insipidus. So that's a super rare condition for a female who is 12 years old. And the doctor was like, no way, and then diagnosed me with type 1 diabetes.
Right.
But the thing is that it like did not take into account at all this like epidemiological factor of it. Which is super interesting. So it was part of the sort of like clinical authority side of that, is that she could think about the population, the patient population, and say, actually, like this patient is 12 years old, and that's super rare. That would be like that the type 1 diabetes is a much more common finding for a patient who is 12 years old with this set of symptoms. Another anecdote, one time I was in college and I put in a couple of symptoms and it told me I had rabies. So not rabies. So anyway, if knowledge coupling isn't present in the EMR today, the question is like, how did it actually influence the EMR then? Because I do want to claim that it did. Some of the principles from it actually did influence the EMR. So here on the left is basically like a modern emergency note from Epic, which is the largest EMR software. And it includes all the different parts of the note that we've talked about, the HPI, the ROS, things like that, end place for a diagnosis, which is just an assessment. So we don't use knowledge coupling today, but much of the note is actually filled in through automatic or semi-automatic phrases that are triggered with just like 1 or 2 keystrokes. So these are the sort of templates that I was talking about in the beginning. This is going to be way too much text on the slide. You don't need to read all of this. But this is a sort of an example of a template. So this is something that I wrote for a physician that I was working with, and we drafted it several times, saw different patients, and then decided like what things to take out or put in. And basically what we were doing here, so this is a negative HPI template. So it's ruling out larger causes of back pain for someone presenting with low back pain. It's specifically ruling out cauda equina syndrome because that's a really emergent issue. But I think that these templates are like a relic of things like knowledge coupling, where we're saying we're perpetuating the idea from EBM that diagnosis is best done by first determining what exactly counts as evidence for a diagnosis, and then forming some sort of logical puzzle saying like what signs and symptoms count in order to make a diagnosis for a disease. But then we're left with the question like, where does that evidence come from and whose evidence is that? And that's sort of where my conclusion ends on, like the electronic medical record tells us what counts as evidence, but whose evidence is it anyway? How do we know that some subjective information and some objective information really equal some assessment or diagnosis? Is it really because of evidence, or is it because we're calling it evidence? Is it really because of like trials, or because we know that it is really true, like it's based in fact? Or is it because we took it from a textbook and we've been running with it for a while? And what does this look like in terms of values? Is this really value free? Or because we have so many different templates to describe the same disease, maybe these things are actually influenced by what sort of symptoms or signs we actually value as clinicians higher than others. And in a broader sense, I think in general that this proves that the electronic medical record is a technology which carries with it assumptions about evidence in medicine that are revealed only through like really cool historical investigation, not to toot my own horn. But I think like it's a tool that we're using every day, but it carries with it some really important assumptions that like we should actually think about and talk about. Anyway, thank you.
Yeah.